Okay, I think we're live. Hopefully. I'm not totally sure. Looks like we're getting there. So, hey guys, we're going live on YouTube. I'm going to answer some of your questions. I had a few comments online that I wanted to answer because they're mostly kind of around some of the same themes with regard to vaginal birth after C-section, which, if you know me, you know that I am a big fan of and I'm very supportive of. So, but there have been some kind of follow-up questions, so I thought I would get to those first, and then we'll see if anybody jumps on that has other questions, and we'll answer those as well. So I'm just going to see if I can refresh my stream here and find myself. Yep, I'm on live. So looks like it's working. If you have questions, you can put them in the comments. Just going to see if this is totally in focus real quick. Sorry. Looks like it is. Okay. All right, cool. So we're live. I'm going to answer a few of these questions from my YouTube comments from recent videos. So, okay, so let's see. First one here is patient on her second pregnancy, went into labor, dilated to about 9 centimeters, ended up with a second C-section, so she was trying for a vaginal birth. She said strongly believed she could have had her birth. How long should you wait to try again? What are the conditions for a vaginal birth after a second C-section? So if you look at most of the data on vaginal birth after C-sections, most recommendations would tell you to have ideally about 2 years between deliveries. So, you know, basically when you have about a year old and a couple months, then it's okay to consider trying again. And otherwise, the conditions for vaginal birth after a second C-section are actually really similar to vaginal birth after one C-section. Generally recommended that it's a low transverse C-section. And then, you know, we talked about it in the videos, but you can look at the calculator to see what your chances of success are. And if you get over about 60% as an estimate, then I would really encourage someone to try. If it's less than that, it doesn't mean you can't try, but it just says, you know, the risks are probably a little higher of a failed trial of labor and a need for a repeat C-section. The risks are higher for that than a scheduled repeat. So that's where that 60% comes from. So hopefully that answers your question. Okay, and let's see. Here's another one from Jojo and Josie. Let's see, given birth twice after 2 C-sections. That's awesome. First scar being an inverted T. And she said the kind of scar that 99% of American doctors would say no to VBAC. She did find big babies, 9 and 10 pounds, fast labor, no drugs. Good for you. So, you know, happy for you. Glad you had success. You know, one thing to talk about there is, and this came up from a couple, I think she had another comment below that. You know, this idea of laboring after a classical C-section or a vertical C-section or a T extension. What's the big deal? Why is that a problem? Why is that different than a low transverse C-section? And the primary concern is that the risk of rupture is probably higher, and you know the range of possibilities for how much more risk is there really are wide. But I was reading an UpToDate, which is a good, reliable, kind of unbiased expert opinion review of the literature, says, you know, anywhere from 1 to 12%. So, you know, if we quote about a 1% risk for a low transverse scar and 12% at the maximum end for a classical or a T-type incision, obviously that's substantially higher. It doesn't mean 100%, obviously, but it's a higher risk. And I think that'd be the main thing that, you know, anyone that was considering that should keep in mind. And it's probably true that, you know, most American OBs would be reluctant to endorse someone trying for a vaginal birth after a vertical incision for this reason. And, you know, I'm really glad in the case for JoJo and Josie that things went well and she had healthy deliveries, and that's great. It's just difficult to know, you know, for the population at large, what the risk really would be. And unfortunately, if a rupture happens, they can be catastrophic and life-threatening. So that's the concern. Not that anybody's trying to tell anybody how to live their life, but you know, those are the kind of things that I would tell people if they were asking me about a classical C-section. Is we think the risk is higher. It's hard to get a definite So hey, I'm just going to jump over to the chat here and see who's jumping on. Hey, Megan, and hey, Didi. Uterine windows, how common is it, and is it dangerous? So, uterine windows, what that means is, most of us have seen those from people who've had a couple prior C-sections. And the idea is that as the uterus heals from that incision, the tissue is thin and not as strong, possibly, as the sort of native uterine tissue would be. We do have some concern that they would maybe be higher risk of rupture. The truth is we don't really know because they're difficult to diagnose before delivery. So sometimes you can see some concerning signs of kind of a ballooning lower uterine segment on an ultrasound. It may look thin, but you really don't know until you look directly at that uterus to see, how thin is it really. I've had plenty of people who went to C-section, had an uncomplicated repeat C-section, but didn't labor, or did labor but went to C-section that didn't rupture. So it's hard to know really what the risk is. It's out there. It's a possibility. Sorry, I'm getting text here. It's hard to say beyond that really what the risk is from those. They are fairly common. And so unless I were to see something on ultrasound or had a consult from a perinatologist that said, this looks really concerning, then I wouldn't let that get too much into my head when I was thinking about trying to counsel somebody about the risk. And then the follow-up question is what causes it. It's really just the healing process. You have to make a scar from where the uterus was opened. And as a result, it's just not as, oh, you're welcome. It's just not as strong. So that's what the window story is. So I'm just going to jump back on the other comments and see if there's other questions. If you guys have questions as you're watching, feel free to put them in the comments, and I'll jump back and forth between those to see what we talk about next. So let's see. Okay, so we're changing subjects now, talking about metformin. Allie asked a question. I was prescribed metformin, 1,000 milligrams a day with birth control, also on Accutane, 30 milligrams a day, all at the same time. She's had some concerns about, is this something that's okay to take all together? Are there any concerns about that? And I think that combination seems reasonable. Typically, if you're on Accutane, it's recommended or required, depending on where you live, that you're on birth control, typically even 2 types of birth control, whether that's birth control pills and a condom or some combination thereof, only because Accutane can cause such bad birth defects if you were to get pregnant. So pretty much always Accutane and birth control pills are going to be prescribed together, so lots of experience with that. And metformin in and of itself, I'm not aware of any interactions between that one and the other meds. So in and of itself, I don't think that's anything to be concerned about. Seems reasonable to me. Okay, so Johnny says, my daughter, her first pregnancy was induced 1 week early of due date and didn't dilate enough due to enough fluid, had to have C-section, pregnant again. Can she have a natural birth? Yes, absolutely. And, she's probably a great candidate. If you want to look at that VBAC video, which is where your comment came from, you can calculate the chance of success based on the exact specifics of her C-section, but suspect probably she'd have a pretty good chance. And let's see, there's some more of these kind of VBACs after a C-section. We've kind of talked about that, so we'll skip over those. That's really about it for kind of recent comments on my channel. So let's go back over here. Didi had a question about metformin and breastfeeding. That's a good question. There probably is some passage of metformin into the breast milk, and so in theory, there might be some concern for lower blood sugar in a baby of a mom who's nursing. But I suspect if there is any getting into the breast milk, it's a very small amount. So I wouldn't really worry too much about it. We've had plenty of people with either diabetes or gestational diabetes who take metformin and then have baby, and I really haven't seen a lot of problems with it. So I think the low blood sugar thing's probably more of just theoretical, and in and of itself not a real big concern. So I think it's probably reasonable. So yeah, let's see if you guys have other questions. Feel free to jump in. I'm just kind of rambling. It's a Friday afternoon. I'm on call. I'm getting some pages intermittently from the hospital here, nothing of which seems to need immediate attention. So I'm just going to kind of keep going. But if you guys have a question, feel free to hit me. Let's see. Also, just a quick plug, we did give away the Vitamix finally hit 1,000 subscribers. Yay! And Jamie was the winner of that. She came by the office earlier this week to pick it up. Hopefully, maybe we'll see her making smoothies on YouTube someday, talking about the benefits. But I was happy to finally be able to give that away after I hit 1,000 subscribers. That was fun. So yeah. Tell you what I might do while just waiting to see if anybody else jumps on the stream is just push a little copy of this over to Facebook to say, hey, you guys, if you want to catch me on YouTube, come on over. So if you guys have questions, put them in the comments. In the meantime, I'm just going to jump on our Facebook page real quick and say, hey, I'm live over on YouTube. Check it out. Let's see if I can. All right. Just going to add a quick link here. Wes is live on YouTube. Here's the link. Come on over. All right, just going to post that real quick and see if anybody else wants to come play. Good question. Reglan to increase breastfeeding. So it may improve breast milk a little bit. However, there's one really serious side effect that worries me a lot. It's rare, but if it happens, it's really bad. So it's called a dystonic reaction. And what that is a neurological movement disorder which can result in either kind of stiffness or kind of weird jerky movements of your arms and your trunk. And unfortunately, it can be permanent. And it's directly related to the number of doses of Reglan, so in other words, the duration of dosing and the amount that you take. So I really avoid prescribing it to breastfeeding moms, and that's because this, if it happens, it's permanent. And I always say, if you've ever seen a person with schizophrenia, they especially kind of been around for a while with their disease, some of the medications have similar side effects, and you'll see them, and they have this sort of really distinctive movement disorder. It's really weird. It's almost kind of like somebody's doing a really bad Axl Rose impersonation, kind of heads moving around, arms are doing weird things. It's permanent. So that's why I don't prescribe Reglan. Fenugreek, of course, is the supplement most people have heard about. I'm glad you were fine. But fenugreek is safer. There's really no known side effects. It does make your urine smell kind of like maple syrup, which is interesting but not dangerous. But probably not as effective as Reglan, but I just worry about the side effects. So I typically just don't prescribe it. And then the other one that you hear people ask about is domperidone, which is I don't even know what it was for originally, but it seems to increase breast milk. Unfortunately, the FDA has put a black box warning on it and basically banned it from being made in the U.S. Some compounding pharmacies are still somehow making it, but it has a very specific cardiac side effect that, again, it can be fatal. And so although it's rare, if it happens to you and you die, you really don't care how rare it was. So I don't prescribe domperidone for that reason either. I always encourage folks, if they're having problems with milk production, to seek help from a lactation consultant. Unfortunately, they sometimes recommend Reglan. But sometimes there's things you can do in terms of how the baby's latching or what you're doing as far as how frequently you're pumping and things like that. So I kind of go back to defer to the lactation consultant, but I wouldn't take Reglan. Okay. So let's see. Kat says, how much does the weight of the baby play a role in your chance of VBAC? It's a good question, and it's not in the model. So if you look at that VBAC video on my YouTube channel here, there's a calculator. You can click on it. It doesn't say anything about how big was your baby. It just talks about the circumstances for why you had to have a C-section. And it's kind of built in a way because they look at the indication for C-section being failure to descend or arrest of labor progress, those kind of things. Those are sometimes associated to the size of the baby. But I do talk to people about that and say, if you had a C-section because your kid was 10 pounds and you pushed for 4 hours and it wouldn't come out, maybe this time if you had a 7-pounder, pretty good chance it'd be fine. So I do take that into account when I'm counseling somebody, to consider what their past history was, and then try to get the best estimation of weight you can with an ultrasound, knowing, of course, there's limitations to that. To that as well. But I do consider it, although we don't have good definite numbers to put in the model. Okay, jump back up here for a second. Sydney said, at what point during vaginal labor delivery do nurses notify you it's time to come? Good question. I mean, typically when it's time to come is, mom's completely dilated, they're pushing. I'm generally within about 5 minutes of the hospital, 10 at the most, and they know that, and so typically they kind of keep that in mind. They're monitoring the patient's labor progress, and they're monitoring how well they're pushing, how much the baby moves when they push, and so they kind of take all that into account, and kind of, it's a clinical estimation of when am I really going to need to be there, and in general they do a good job. The majority of patients that we treat around here use epidurals for pain management. So it's a little bit easier if all of a sudden the mom's made great pushing progress to say, hey, just breathe through a couple contractions till Wes can get here. And it's not usually a problem. Every now and then somebody goes super fast and surprises you, but more times than not, the nurses do a good job of knowing when they need to call us. So it's a good question. I was getting a lot of questions over the last few days about travel. I think, school's getting out, and people are planning some vacations and happen to be pregnant, and what's the role of that. And I'm going to make a video I've already shot but need to edit, that talks about that in some detail. But to give you like the sort of the gist of that chat, generally speaking, it's perfectly safe to fly as a pregnant person in sort of commercial airplanes where the cabin's pressurized, and it's not some little puddle jumper. They typically pressurize the cabin to about 8,000 feet. And that's plenty safe if you're pregnant or not pregnant to breathe air like that's kind of like if you went up to Snowbird for the day. You might notice a little mild shortness of breath, but if you're an otherwise healthy person, it's not dangerous, and also not dangerous for the baby. So as far as the actual flight itself, don't really think there's any danger there. Long haul, like flying across the country or flying to Europe or Hawaii or whatever, a little bit more risk maybe from the perspective of blood clots, so venous thrombosis in your legs. So I always tell people on long flights especially, make sure you get up and walk around every couple hours, stretch your legs. I mean, most people have to go pee anyway, so just get up, walk around, go pee, stretch your legs, pump your calves, move around, just to get the circulation going, because you're sitting in this cramped, tiny airplane seat. If you just don't move the whole time, the blood is really pooling in your extremities, your waist is bent, your knees are bent. There's a real good chance for blood to kind of pool, and pooling of blood in a vein is one of the key components to leading to a blood clot. It's called venous stasis. So to combat that venous stasis, get up and move around. The other trick is hydrate, because it does thin the blood a little bit. Also to make you get up and go pee, so it kind of has a 2-for-1 effect. And then maybe consider wearing like support socks. There's some evidence in the surgical literature that these type of TED hose or support socks reduce the risk of blood clots in surgery, so it would seem reasonable to think that they might also reduce the risk for someone traveling long distance. So I recommend those. And the last thing you kind of think about is like, well, where exactly are you going? What if you happen to have the baby while you're there and you're some distance from home? So we always kind of talk about that a little bit. Apparently most commercial airliners will let you fly till 37 weeks, which to me seems like way too long, way too late in pregnancy. I usually tell folks, 34, 35 weeks is probably about as far as I'd feel comfortable going. I usually encourage folks to stop by the office. Let's check you, make sure everything looks okay before you jump on the plane, just to play it safe. And of course, even then, no guarantees, but hey, better than nothing. And then probably from there, you're going to be fine. So those are my random thoughts on travel and pregnancy. Stay tuned for a better put together video on that sometime soon. So just looking to see if anybody else has questions. Nothing really is jumping up on the comments here. So if anybody else is watching that has a question, feel free, please, to ask a question. Just going to roll back through some of these other comments on my videos to see what else is out there. Most of them lately are talking about the smoothie giveaway that I had. Everybody was hoping to win, and I was glad that we did get a winner. So I'm just going to have to get past through some of those comments. There's a bunch. There was one recently also I did on caffeine use in pregnancy, and I think I did that on a Facebook Live maybe. But it was a study that recently looked at the risk of, or what are the potential risks with caffeine intake and while you're pregnant. And one, as it turned out from this one study, was a higher risk of kids actually developing childhood obesity later in life, all the way out to like 8 years, I think it was. They showed a potential higher risk of being overweight, particularly in the group of moms who had what they considered high amounts of caffeine daily, which was like 200 milligrams of caffeine a day, which is something in the neighborhood of 3 to 4 cups of coffee. Kind of depends on the type of coffee. But so I usually tell folks maybe 1 a day is probably reasonable. But even in that low group, they did show some slight risk, even at about 3 years of childhood obesity, but it didn't persist beyond that. And the risk wasn't as high. So, you know, I think that's something to keep in mind. Maybe 1 serving a day of caffeine is reasonable, but even then you might think about not having it at all if you can survive without it. I personally can't have a conversation without a cup of coffee. So, you know, I'm not going to tell anybody not to have 1 cup to get through the day. But it might be the best thing from a management of the risk of childhood obesity standpoint at any rate. So let's see. Life with May has a question. I had a miscarriage back in October, and cycles have been heavier since then. Should you be concerned? Not necessarily. You know, there's a lot of questions in that question that I would have. You know, one of which was that your first miscarriage? Because if you've had multiple miscarriages, you got to start wondering about. It's the cat and dog fight back. I don't know if you guys can hear that. You know, do you have fibroids? Could that be a thing? Is that causing miscarriages? Maybe some other issue inside the uterus. So ultrasound might be a good idea, especially with the heavier periods. Even if there hadn't been a history of a miscarriage, that's usually a pretty typical step in the evaluation. So I'd maybe consider ultrasound if you haven't already. If that was normal, then I really wouldn't be too concerned about it from the miscarriage standpoint if there's nothing else to the history there. So, this cat and dog are going nuts. Oh, man. Let's see. Let's see here. Going to look back and see if we have other good questions. Well, some more questions about vaginal birth after 2 C-sections, which I did make a video about. Just going to see if there was anything specific in this question. 2 prior C-sections, looking at a third. Placenta's out of the way, no concerns about accreta. Trying for VBAC. Part of her was leaning towards a repeat C-section just from fear of the unknown. And the question was is it possible to induce for a VBAC? And the answer is it is possible. We recommend trying not to, only because there's evidence that spontaneous labor has a higher chance of success than induced labor. Hey guys, let me know if you can hear this crazy cat fight that's going on in the back. If so, I probably need to go break it up. It's kind of mildly distracting. Let's see. Sydney says, if first pregnancy tested negative for strep, is it likely for following pregnancies to be negative, or is it all just random? I think it's really mostly just random. Supposedly about 1 in 3 pregnancies, the mom will test positive for strep. I've seen that a fair amount. You know, that seems to be a pretty reasonable number, although there definitely seem to be patients who like always test positive or always test negative. So there may be other things to it, but on average it's about 30%. And I'd say that the distribution, at least as far as I can tell, seems to be fairly random. So we do recommend testing every pregnancy. And if you were positive in a prior pregnancy but negative in your current pregnancy, we don't treat. unless there's a history of group B strep related infection in a newborn, because we know that the risk of recurrence is higher for that. So we do the culture, but treat regardless, even if mom tested negative, if the previous baby was affected with strep. Okay, I'm gonna go break up this fight. Don't go anywhere. Be right back. Can you be nice to the cat? All right, I'm back. Okay, so looks like I'm still caught up on questions here. Let's just see. I'm just going to go back through some other comments and see if anything else pops up of interest here. Let's see. If you had, here's a good question. If you had an ectopic pregnancy that was ruptured and then had one C-section on the same spot, would you consider that 2 C-sections? Can you try for a vaginal birth? So I think that the question she was asking was, she had 2 scars on her abdomen, one of which was from an ectopic pregnancy, one of which was a C-section, and did that matter? And my answer, of course, was no. It's not about your skin incision; it's about the uterine incision. And of course, for an ectopic pregnancy, there's no uterine incision. And although we sometimes make the skin incision in the same place, that's okay because we're only concerned about the uterus. So I reassured that person that perfectly fine to go ahead and try for a vaginal birth. So it was a good question, though. Let's see. Looking back to see if anybody's throwing any more comments on here. I'm glad you guys, if you enjoyed the cat fight. It seems to have reached a settlement now. All right. Let's see if there's anything else going on. Does McKay have see-through sheets for C-sections? They do. Yeah, so they have this... so when you drape the patient for the C-section, sort of the traditional surgical drape is just solid, disposable paper. But the ones at McKay actually have a clear top to them, and then that paper backing, and actually it can be separated, and you can see through the sheet. Now, honestly, you can't see a ton because you're laying flat, and then you're trying to sort of look up and over your belly, so you can't see a ton. But sometimes, we can put a mirror off to the side. You can kind of catch the reflection that way and see it through the sheet. And then, of course, when the baby comes out, you can just hold them right up to the mom. So they do have those. And I've used they're always available. Interestingly, most people don't want to see. So I offer it a lot, and I get a lot more no's than I do yeses. But it's definitely out there as an option for people at McKay. So yeah, good question. Let's see. We'll just go back, see if there's any other questions that might be interesting to other people here. And this is just a plug. I have this one video called "Is 35 Too Old to Get Pregnant?" And of course the answer is no. But it's funny because I get a lot of comments like, "Well, my mom had me when she was 38." Well, it wasn't really the point of the video. It was just a starting point for a discussion. And in that video, we talk about testing for chromosomal abnormalities and other issues that are associated. But I just find that amusing when one of those pops up every now and then. By no means am I trying to say, yes, it's too late, you can't do it. So I found that one entertaining. Let's see. So we'll go back, see if there's any other comments here. Is it possible to have a VBAC after babies are due 17 months apart? And the answer is yes. The only thing you'd say to that is that if the deliveries will be about less than 2 years apart versus 2 years apart or more, then there's perhaps a little higher risk of uterine rupture, but not significantly so. So I don't think that's a deal breaker for somebody. I tell people kind of like 2 C-sections, like, well, maybe it doubles the risk. So maybe you go from 1% to 2%, which is not a huge increase. And I don't think by any means is something that should be a no for somebody. But I think you should be aware that that shorter delivery interval could increase the risk a little, but not substantially. Let's see. So, yeah, we'll go back. Let's see, Sydney. Do your patients only request you do a birth vlog if they know they're having an epidural? I'm trying to think. I don't know that anybody has had the combination of an unmedicated birth and a video yet. I'm not certain on that. I kind of don't think I have. But part of that's because there's actually not that many unmedicated births around. They do happen, but they're just not very common here in Utah for whatever reason. And in all honesty, I don't blame anybody. I'd have an epidural every time. I've had a couple kidney stones, and I swear if somebody would have come to my house and said, "Hey, we can give you an epidural and you can have that kidney stone," I would totally have had the epidural. I had my kidney stones naturally, and it was awful. So yeah. But I suspect eventually somebody will come around unmedicated that we do a video for. It's just a matter of that combination of factors. All right, well, you guys, if you have other questions, throw them up there. I'm just going to look back through my other comments and questions and see if anything's interesting. Let's see. There's a question about benefits of low-dose aspirin to reduce the risks of preeclampsia. And yeah, that is a recommendation for people who either have a history of high blood pressure or a history of high blood pressure in pregnancy, even if they don't have high blood pressure other times, or even just straight up preeclampsia in pregnancy. It is recommended. There's some studies that show that it might reduce the risk of preeclampsia happening again in another pregnancy, so we do recommend that. It's hard to know exactly how much it reduces the risk, but hey, any help on that one is a good thing, so I do recommend that. Let's see. Here's another question about somebody who had a C-section after a failed induction, it sounds like, for diabetes. And since that time, she's lost 50 pounds, which is awesome. And then still at about 30 pounds less than pre-pregnancy from the last time around, which is, again, fantastic. Thinking about another baby, thinking about a VBAC, wanting to know what you could do to get ready. And the main thing was I just kind of said, keep doing what you're doing, because the pre-pregnancy BMI is very predictive. That's, of course, your height and your weight. They are the two of the main things you plug into that VBAC calculator, and they are two of the most predictive in terms of your chance of success. Separately, also, there's evidence that excessive maternal weight gain is a risk factor for preeclampsia. So not only coming in at a healthy weight for your height, but then not gaining too much weight once you get pregnant is also recommended. And there's a video on my channel called How to Avoid the First C-Section, and one of the things it talks about is looking at those Institute of Medicine guidelines for how much weight to gain in pregnancy. And it's basically based on if you're a underweight, normal weight, overweight, or obese, and those are all BMI-based calculations, and then it gives you sort of a recommended weight gain. And as long as you stay within those recommendations for your BMI, then that in of itself was not a risk factor for C-section, but if you exceeded the weight gain recommendations, it was. So I do encourage people to take a look at that, and we do talk about that in terms of weight gain goals for the whole pregnancy when counseling somebody who's pregnant. Let's see. Yeah, no other real questions right now. Looks like Dee Dee and Sydney are having. I'm glad you guys are chatting. That's good, back and forth. Let's see. I'll just kind of go back and see if there's other questions. If you guys have others, hit me. Let's see. There was a question about the chance of uterine rupture. Is it associated with the delivery interval? So the answer to that one was yeah, if it's less than 2 years versus more than 2 years. So I think I've talked about that one once or twice. Let's see. Well, I'm not seeing anything else super great here. I'll roll back over to the comments and see if you guys have anything, and if not, that's okay. I'll probably wrap this up here in just a minute. But thanks for you guys for watching. It's been fun. It's been just kind of an easy Friday afternoon for me, waiting on babies to start coming in, which will probably happen later on. So yeah, thanks for watching. There will be a video coming out pretty soon, like I talked about, on travel. So if you're curious, you can check back in a day or two to see if there's any other comments popping up anywhere that anybody wants me to answer. It doesn't look like it. So I think we'll call it good for today. Thanks for watching, you guys, and thanks for your questions. And we'll catch you next time. A lot of these are kind of Friday afternoon streams, either on this channel or over on Circle of Life's Facebook page, which, if you're curious, you can just search on Facebook, Circle of Life Women's Center. And I do those some Fridays or every other Tuesday or so. So, hey, thanks for watching. Hope you guys have a great weekend. Hopefully I won't be up too much, delivering a lot of babies this weekend. I'm on call. So take care. Have a good day. See you next time. Bye.